Slide 1 Health Promotion in the UK, Bridging Theory, Practice and Policy. Hello everyone, my name is Timothy Elliott. Let's cut through the jargon and dig into how health promotion actually functions here in Britain. Today's session will focus on three key areas: the theories behind public health strategies, how these ideas translate into real-world programs, and the tangible effects organisations have on communities. I'll be highlighting how these moving parts interact with, and occasionally clash against, Britain's unique social and political landscape. By the time we wrap up, my aim is for you to have a clearer grasp of not just effective tactics in this field, but the underlying reasons for their success. We'll also confront the stubborn systemic barriers that still trip up progress. Plenty to unpack. Let's get into it. Slide 2, Evolution of Health Promotion Models. Health promotion has never remained static. Its development has progressed alongside changing societal priorities, evolving political viewpoints, and fresh scientific discoveries. Consider this condensed historical overview: 1950s medical framework. This period focused primarily on curative measures within healthcare. Landmark achievements, such as the extensive rollout of polio vaccines, are rightly hailed for slashing childhood illness and death rates. Yet this approach, centered squarely on medicine, often overlooked wider social and environmental factors shaping health outcomes. The success of polio immunization, for instance, relied on a narrow principle: target a single infectious disease to curb its spread. Few at the time considered factors such as housing standards, nutritional access, or employment stability as fundamental contributors to population health. 1980s behavioral approach. The 1980s witnessed a shift in discourse towards individual accountability for health. Initiatives such as the Don't Die of Ignorance campaign sought to combat HIV/AIDS transmission. While these efforts raised public awareness and may have influenced infection rates, their surface-level impact masked unintended consequences. By assigning blame to those perceived as engaging in high-risk behaviors, such campaigns fostered stigmatization of marginalized groups, notably gay and bisexual men. The moralistic overtones, which framed health as a matter of personal virtue, exposed how individual-focused strategies could disproportionately affect vulnerable populations. This approach often neglected systemic barriers faced by these communities, such as discrimination, unequal access to targeted healthcare provisions, or financial instability. 2000s Social Determinants Framework. By the early 2000s, emphasis on societal influences on health took hold. Seminal reports like the Marmot Review, 2010, highlighted connections between poverty, education, and lifespan disparities. For example, life expectancy for a child in Blackpool was shown to be up to 14 years shorter than for one in Westminster. Such sobering inequalities challenged the notion that health outcomes are solely determined by personal choices. Instead, they underscored how inequities in income, housing, education, and local infrastructure shape well-being. Advocates of this framework called for structural policy reforms, cross-sector partnerships, and a focus on addressing systemic drivers, rather than symptoms, to reduce glaring health disparities. Salutogenic approaches in the 2020s. Recent years have seen a pivot towards salutogenic principles, which reframe the discourse by asking, what fosters health, rather than the traditional focus on what causes illness. Take Scotland's community resilience hubs, established during the COVID-19 pandemic, as a case study. These initiatives moved beyond narrow virus management strategies, prioritizing instead the development of local capacities, mental well-being initiatives, and expanded social support networks. The goal? To foster environments where communities not only endure, but flourish, leveraging existing strengths and resources to sustain health. Academic context. As highlighted by Tones and Green, 2004, shifts in health promotion models align with broader societal change. The UK's transition from paternalistic, top-down policymaking to frameworks emphasising community agency reflects ongoing tensions within the social contract. This contract has faced growing strain in recent decades, from austerity-driven policies and welfare restructuring to the socio-political upheavals of Brexit. Such dynamics underscore how health promotion strategies cannot be disentangled from the wider political and economic landscape. Slide 3. To examine the friction between these frameworks, consider two influential approaches shaping contemporary health strategy in Britain. Medical approach. The NHS breast screening scheme offers a clear case study. While Cancer Research UK 2023 reports a 20% decline in mortality for eligible demographics, surface-level achievements mask uneven participation. In Tower Hamlets, uptake rates hover around 54% compared to Surrey's 78%, a gap reflecting systemic blind spots. Linguistic hurdles, cultural disconnects, and logistical challenges, rigid appointment slots, limited childcare options, frequently go unaddressed. Standardized clinical pathways, while efficient on paper, ignore the lived experiences of women in deprived areas, managing precarious employment, care responsibilities, or historical distrust in medical systems. Socio-structural approach. Glasgow's Deep End project exemplifies an alternative strategy. By linking GP practices with community groups tackling homelessness, addiction, and psychological distress, the initiative recorded a 22% decrease in hypothermia-related emergency admissions, BMJ 2022. Such outcomes highlight how interventions addressing material deprivation, substandard housing, unemployment, isolation, can alleviate pressure on acute services. Yet sustainability remains precarious. Reliance on temporary grants for 80% of funding jeopardizes lasting impact. Without systemic fiscal commitment, innovative programs struggle to outlive pilot phases. Core Dilemma 1 might question whether narrowly clinical methods become morally indefensible when preserving life without challenging inequity. Alternatively, could socio-political models overestimate policymakers' appetite for redistributive investment? A synthesis of both paradigms appears optimal, yet the ideological clash, individual agency versus collective duty, continues to polarize health discourse. Ultimately, neither biomedical precision nor structural ambition alone can resolve this stalemate, leaving practitioners navigating a fractured landscape. Slide 4. Effectiveness, data versus reality. The real-world effects of health interventions, evidence rarely tells a straightforward story. Take the 2018 levy on sugary drinks. While sales of taxed beverages fell by 44%, initially celebrated as a triumph for obesity policy, hidden trade-offs emerged. Research by the Food Foundation, 2023, revealed a 15% spike in sugar levels within takeaways across disadvantaged postcodes, likely compensating for lost revenue while catering to established dietary preferences. This underscores how fiscal deterrents risk triggering compensatory consumer adaptations, undermining their original aims. Similarly, the decades-old 5A-Day initiative, rooted in behavioral nudges, shows mixed outcomes. Though widely recognized, only a third of Britons consistently hit this target, plummeting to 12% in low-income households, ONS 2023. National averages here mask stark disparities, with affordability and food accessibility gaps, rendering simplistic awareness campaigns ineffective for marginalized groups. Case study, Compromise in Practice. Leeds, Healthier Together, illustrates both the potential and friction of cross-model collaboration. By tasking GPs with referring patients to subsidized cookery workshops, blending clinical protocols with grassroots nutrition education, participating neighborhoods saw diabetes incidence drop by 40%. Yet as Rutter et al. 2019 observe, such integration faces resistance. Clinicians often resent roles encroaching on social work, while council teams cite limited training to handle health-specific metrics. These tensions expose a broader paradox. Hybrid models demand interdisciplinary flexibility, yet institutional frameworks remain rigidly siloed. Slide 5. Every contact counts. Aims and context. Every contact counts. This initiative tackles type 2 diabetes in Bordesley Green, Birmingham, where 43% of households face financial hardship, Birmingham City Council 2023. Existing strategies have often overlooked cultural, language, and income-related challenges. To bridge these gaps, the project prioritizes 3 approaches. 1. Culturally tailored engagement. Working closely with Somali, Pakistani, and Caribbean community leaders, we redesigned health resources to align with local traditions. Generic advice, such as replacing white rice with quinoa, was replaced with practical steps like switching to wholemeal chapati flour or adjusting portion sizes for rice-heavy meals. Testimonials from residents were woven into outreach materials to strengthen relatability and trust. 2. Flexible healthcare access. Evening GP clinics were introduced across 15 practices to accommodate shift workers. HealthWatch 2022 reports that 38% of locals skip routine checkups due to work commitments. Extended hours boosted attendance rates, enabling earlier diagnosis and consistent care for those previously excluded by standard appointment times. 3. Environmental advocacy. Acknowledging systemic barriers to healthy lifestyles, the team secured $200,000 in council funding to develop green spaces. Evidence from NICE 2016 confirms that affordable access to parks and footpaths correlates with higher physical activity levels, particularly in low-income areas. Community voice. Mr. Ahmed, a local participant, summarized the initiative's ethos. I believed diabetes was inevitable. Now I see it's my decisions, and the council's, that shape my health. His reflection underscores the dual role of personal agency and policy in driving well-being. Slide 6. Implementation challenges. During the implementation phase, we encountered several significant challenges which offer valuable lessons for those involved in health promotion initiatives. Resistance from GPs. Healthcare professionals, often stretched thin, frequently resisted initiatives perceived as extending beyond clinical duties. Phrases like, "We're doctors, not social workers," were common among local GPs. To mitigate this, a community liaison nurse was brought on board to strengthen collaboration between clinical teams and residents. This role involves regular attendance at community events and actively addressing gaps in communication and awareness of local health priorities. Cultural barriers. Engaging men proved particularly difficult. Early diabetes workshops and cooking classes were dismissed as activities for women, resulting in low male attendance. Collaborating with local mosques, we integrated health-focused messaging, specifically diabetes prevention and nutrition, into Friday sermons. This strategy not only boosted male involvement, but also reinforced the notion of shared responsibility in health matters within the community. Issues with data timeliness. A major challenge stemmed from reliance on outdated ward-level statistics. Public NHS digital data, often delayed by 2 to 3 years, struggled to reflect real-time shifts, especially amid pandemic-related changes. To bridge this gap, we turned to social media and community-run WhatsApp groups, deploying rapid polls and surveys. While unconventional, this method yielded immediate insights into dietary trends, exercise patterns, and obstacles to healthier living. The Health Foundation, 2023, highlighted this approach as a model for enhancing traditional data gathering through community-driven innovation. By prioritizing adaptability and local engagement, these strategies not only addressed immediate barriers, but also fostered sustainable community-owned health interventions. Slide 7. Results and ethical dilemmas. Measurable impact. Within the first year, nearly 7 in 10 participants reported adopting healthier eating habits, such as regularly incorporating fruit and vegetables into meals, while 4 in 10 attended previously avoided routine screenings. Preliminary data indicates these changes may lower long-term complication rates, potentially easing pressure on NHS services. Ongoing challenges. Despite progress, persistent barriers remain. Many participants highlighted the unaffordable cost of nutritious food and gym access. While free swimming passes were offered via partnerships, e.g. Birmingham on the Move, frustration persists over the lack of consistent council-funded facilities. As one resident noted, "Why should we rely on temporary schemes when proper local amenities are scarce?" Parents also emphasised the uphill battle against junk food marketing. Cheap, unhealthy snacks dominate areas around schools, contradicting health messaging. In response, we've begun advocating for restrictions on fast food advertising near educational sites, a move illustrating the need for both grassroots action and legislative reform to reshape community environments. Balancing optimism and realism. Smith, 2021, warns that spotlighting local achievements risks masking entrenched systemic inequalities. An ethical dilemma emerges. Can we celebrate progress without addressing the root causes of health disparities? Navigating this tension, offering communities hope while demanding accountability from policymakers, remains a core challenge in health promotion. Acknowledging this duality is critical to fostering trust and driving meaningful, lasting change. By blending measurable outcomes with candid reflections on structural flaws, this approach aims to empower communities without sidelining the urgent need for broader societal shifts. Slide 8. PHE's Legacy Triumphs and Tribulations. Examining Public Health, England's Legacy, 2013-2021. The Role of Public Health England, PHE, offers insight into the structural challenges influencing national health strategies. Though disbanded in 2021, its 8-year tenure provides lessons on both effective policymaking and the risks of institutional fragmentation. Progress under PHE. Notable achievements emerged during PHE's oversight, particularly in tobacco control. Adult smoking prevalence fell from approximately 20.2% to 13.3%, driven by stricter regulations, including standardized packaging, and campaigns promoting vaping as a lower risk alternative. These outcomes highlight the value of sustained, multifaceted approaches grounded in research. Controversial dissolution. PHE's abolition followed intense scrutiny of its pandemic readiness and COVID-19 response. Its functions were redistributed across 3 bodies: the UK Health Security Agency, the Office for Health Improvement and Disparities, and NHS England. Critics, including local authorities and academics, argued this restructuring created overlapping responsibilities and weakened coordination. A 2022 Lancet editorial condemned the haste of the reforms, stressing that fractured leadership jeopardizes crisis management. Devolved approaches, diverging outcomes. Health promotion strategies vary markedly across the UK's nations, reflecting differing priorities and funding models. Scotland's Making Every Contact Count (MECC) programme, backed by 10 million yearly, has supported consistent outreach. Conversely, Wales has struggled to replace EU-backed initiatives post-Brexit, leading to cuts in workplace wellness projects and community mental health services. Such disparities underscore a postcode lottery in access to resources, where geographical location directly impacts the scope and quality of preventive care. Slide 9, The Road Ahead, a call to action. Closing reflections, strengthening health promotion in the UK. As we wrap up, it's worth considering how the UK might bolster its approach to health promotion. Let's explore actionable steps. Blending approaches. Rather than pitting medical frameworks against social ones, blending their strengths offers a smarter path. A resilient strategy would combine clinical rigor, think data-driven treatments or targeted screenings, with proactive efforts to tackle societal factors shaping health. Practical adjustments matter here: culturally sensitive guidelines, flexible clinic hours, or outreach that aligns with community needs. Shifting decision-making. Closer to communities. Centralized systems often miss the mark on local nuances. Empowering councils in places like Birmingham, Cardiff, or Glasgow with greater funding control could spark tailored solutions. Grassroots voices have long argued that Westminster's one-size-fits-all policies overlook regional realities, language diversity, trust gaps in marginalized groups, or job market fluctuations. Local leaders, attuned to these dynamics, are better positioned to allocate resources effectively. Broadening success metrics. While BMI and mortality rates still matter, they paint an incomplete picture. Incorporating mental well-being surveys, social cohesion indicators, or measures of community agency could shift focus toward what builds health, not just what damages it. This aligns with the salutogenic model, which asks, what keeps people healthy, rather than solely fixing what's broken. Final considerations. With the NHS turning 75, a pivotal question arises. Should we settle for patching people up or invest in preventing illness altogether? The answer shapes everything from budgets to societal equity. A forward-thinking system would tackle root causes: poverty, housing insecurity, educational gaps, while fostering collaboration across sectors like housing, education, and local government. Initiatives such as Glasgow's Deep End Project or Bordesley Green's Every Contact Counts prove that hyper-local, community-led efforts work. But scaling these requires sustained funding and political backing. Celebrating small victories matters, yes, but not at the expense of confronting systemic barriers. Key takeaways. Frameworks aren't foolproof. Whether medical, social, or behavioral, every model has blind spots. Scrutinizing unintended consequences, like stigmatizing language in campaigns or rigid protocols, is non-negotiable. Context is king. Projects thrive when they listen to communities. Flexibility and cultural awareness, as seen in Every Contact Counts, often determine success. Structural fluidity, public health. England's restructuring highlights how political wins reshape systems. While fragmentation poses challenges, it also invites innovation, if stakeholders seize the chance. In short, health promotion isn't a side project. It's foundational to rebuilding trust in the social contract, If we're serious about equity, empty rhetoric won't cut it. We need strategies that blend grassroots ingenuity with national coordination, backed by funding that outlasts electoral cycles. Thank you.